Hello, good evening, everyone, and welcome back to our IVF webinar. And of course, we have another special guest. Some of you might already be familiar because this is Dr. Uliana Dorofeyeva. And as you probably know, she's been here before and she had many webinars with us already. And it's always great to have you back. And how are you feeling tonight? How are you? It's good to have you back, as I mentioned.
Thank you, Carolina. I'm great. Thank you. And this is a big pleasure for me to be back with IVF Media and with your company, and also to talk to our patients. My pleasure.
It is definitely a pleasure to have you back. And of course, tonight we will discuss quite important topic. And this is a topic that, and that of course brings lots of questions. So I'm sure you will have some. And before you will have a chance to ask your questions, we will simply start with the presentation on early menopause and of course the genetic background. And afterwards, remember to type the questions in the chat section and Dr. Uliana definitely will answer them for you. So don't hesitate to go ahead and do it. And if you don't know already, Dr. Uliana is the Director of International Cooperations IVMED, which is located in Kiev. And of course, she's also the Medical Director at OVOGENE, which is an egg donor bank in Ukraine. So it's definitely wanted to have you back once more. And of course, remember that if you would like to ask anything, you can type the questions during the presentation or afterwards. And I'm sure Dr. Uliana will be happy to help you out with them. Don't hesitate. And that will be it from me at this point. I guess we can start with the presentation, our topic tonight. Yes?
Yes, absolutely.
Perfect. Let's go ahead then.
Thanks. So we are going to talk tonight about earlier menopause and genetic background. But before we will move to the menopause, let's start from the beginning. And the beginning is this is understanding our resource and the most valuable resource for women is our ovarian reserve. And even before a girl is born, it is already predicted how many follicles, how many years of ovulation and menstruation she will get, what will be her response, what will be her antral follicle count, what will be her AMH during every period of her life. And you can see the graph of that the maximum number of antral follicles is during the antenatal period of growing of the fetus. And before the delivery, we are getting the first, getting lower the numbers, and we deliver the fetus with the certain number of the antral follicle, which is about 2 million. And during the period of puberty, until the puberty and the first menstrual period, there is a certain classification of every girl who is getting into her puberty regarding the potential and number of her antral follicle count. And we are left with about 400,000 to 500,000 antral follicles on a different level of their growth. And during the fertile period, which is usually between starting from 11 and up to 50 in average years old, we have about 400 to 500 menstrual cycles, meaning we are producing between 400 to 500 oocytes, which are getting into the mature stage. So they are getting into the stage of the ovulation, and this is potential number of those who might be fertilized, who might produce embryos, and which might be used for the fertility treatment. And we need to understand by this that 99.9% of our follicles are lost, because during every menstrual cycle, on the beginning of the follicular phase, our ovaries are recruiting certain number of the follicles. depending on which ovarian reserve we have in this specific term of our development. If we are in our 20s, normal ovarian reserve for every cycle in terms of number of antral follicles would be between 20 to even 50 and 60. Meaning these are follicles in their class 2 or class 3 of their growth, which can be recruited, which are already sensitive to FSH, and they can potentially grow if they will receive enough FSH. But because our hypophysis is producing very low numbers of FSH, only one follicle in the natural cycle will be recruited. And all others from those 20 to 50 in our young ages, they will be on the stages being able to be potentially recruited. But if they will not receive enough FSH, they will just get into atresia, meaning we will lose them. And never again it will be possible to use them again. If we are already in our 30s, number of antral follicles will be less. It will be between 10 to 30 in average. But still, every menstrual cycle, we will be recruiting this number of follicles, and either we are using them or not. If we are moving to our 40s, we all understand that there is a decrease in total number of antral follicles, meaning every cycle potential recruitment will be less, but still there is potential recruitment. And then if we are moving into the process of menopause, and if we will go back to our period of life, it will be, we will talk about age when it comes. So still we can recruit, we can produce some amount of follicles, but this amount is very, very low. So what is menopause? This is an age-dependent, permanent cessation of the menstruation and ovulation due to ovarian failure. This is physiological process, but of course it depends in which period of time this is happening of our age. And it is diagnosed after 12 months without a menstrual period. This is very important to define a definition of menopause, because many patients, if they started to get irregular menstrual cycles, or they are missing 1 or 2 cycles, or they have a delay in their next cycle to come, and they are in their older age, they think they are already in menopause, but this is not true. This is absolutely different period, and menopause, it will be only if you have no menstruation during your 12 months. And the median age of natural menopause varies according to the ethnic group, genetic, demographic, social, economical, dietary, and reproductive and different behaviors. The international range of age of natural menopause is between 44.6 to 55 years, and it's quite variable worldwide. Some scientific publications, they've been reporting the age of natural menopause is 54 years in Europe, 51.4 in North America, 48.6 in Latin America, 51.1 in Asia. And this is very important to understand these changes in the woman health, because the fertility changes and the hormonal regulations, they are very associated with the somatic status. And the health wellness regarding the early or late menopause, if we can control this, or we can predict, or we are taking care about this, we can reduce the risks of chronic diseases that will reflect also the health of our society and our patients. So you can see the distribution of the age of menopause, and you can see that mainly it's happening after 45, with the middle average age in something between 51, 52. But there is a condition then earlier than 40 years old. Some of the patients, they are getting to menopause, so we call this also a specific disease, a premature ovarian failure, and we will talk about this later. we can see the changes mainly in the hormonal production, in the endocrine production, mainly, and the most important predictor right now, this is anti-Muller hormone, also FSH, LH, inhibin, estradiol, etc. But now, more and more, we started to talk about genes. Recent genome-wide association studies have identified over 44 genetic variants of genes which are associated with age of onset of natural menopause. And genes linked with menopause can be classified into three major groups. Genes implicated with genome stability, which can be DNA repair, immune function, and mitochondrial biogenesis. And biological and epidemiological data indicate that reproductive performances, age of menopause, and longevity of interlink through common genetic factors, which play a pivotal role in DNA repair and genome maintenance, which have been linked before the process of aging. Meaning, again, we are talking that somatic status and somatic health is also responsible for fail to reproductive and subsequent occurrence of menopause, and reproductive performances may be strongly linked with physical condition of the woman and may be a very good predictors of general health in the later life of the patient. So if the menopause starts before 40, we call this as a premature menopause or premature ovarian insufficiency. If menopause is detected between 40 to 45 years old, we call this early menopause. And the stage when we have irregular menses with the last 12 months or the absence of menstrual bleeding for more than 3 months but less than 12 months, we call this perimenopausal stage. So this is a stage when many changes are happening, and this is the time when we need to take a responsibility to be checked by our doctor, not only by gynecologists, but also endocrinologists. Also, gynecologists will refer you to the specific doctors whom you also need to be checked by, and we will talk again more about this later. And before the age of natural menopause occurs, hormone estradiol becomes insufficient. The latter of primarily due to the follicle aging, leading to ovarian failure, or secondary due to granulosa cell apoptosis or epigenetic factors. And IMH is also predictive factor. And now it is routinely used to evaluate ovarian reserve. IMH level decrease with age, and it's more consistent predictor of ovarian age than the antral follicle count, because by antral follicle count we can check and we can see only follicles on the later stage of the development, and IMH will show us those preliminary follicles which can potentially grow during the next several ovulation or stimulation cycles. So what we should expect if we will give additional dosage of FSH, not just the physiological dosage, which will be given by our hypophysis, but also the additional ones. And you can see the graphs showing green sector, which is the optimal anti-Muller hormone, and red, which is already decreased. And we will talk how it is associated with the timing when the menopause will start. And also for some patients, but this we can talk about young patients, IMH can be very high for those, for example, as PCOS patients. But early menopause can be reported to be associated with the higher risk of cardiovascular diseases, cause mortality and osteoporosis. A late menopause has been associated with the increased risk of breast cancer, endometrial, and ovarian cancer. So identifying the link factors of menopausal age among postmenopausal women especially those who are amendable, may help prevent also morbidity and mortality for the women. And ovarian aging studies, so how we connect IMH level with the period when the menopause will start. So this was not a huge really study, but it included 400 women. The mean age was 41.5 years. And the median IMH level was 0.68 nanogram per mil. And they were checked during the 14 years period. And IMH strongly was predicted time to menopause. Among women with the baseline of IMH level below 0.2 nanogram per mil, the median time for menopause was 6 years, 5.99. In the between 45 to 48 years old group, it was 9.94 years. And in the group between 35 to 39 age, it was higher. With higher baseline IMH levels above 1.5, the median time for menopause was 6.22 years in the oldest age group and more than 13 years in the youngest age group. Also, these scientists, they defined that smoking significantly reduced the time to menopause. So still, if we are even having quite low IMH, we still have time until which we will be in the, let's say, total menopause, because still there will be a period of the perimenopausal stage. What is premature ovarian insufficiency? This is a clinical syndrome defined by loss of ovarian activity before the age of 40, and it's characterized by menstrual disturbance, which is amenorrhea or oligomenorrhea, with raised gonadotropins and low estradiol. The possible mechanisms of premature ovarian insufficiency can be three. So when can we decrease and in which stage can we decrease the number of follicles? This can be during the primordial stage, that we have less number of primordial follicles. So this is something what can be detected and controlled by the genetics. We can have increased atresia depletion, or we can have altered follicular maturation. So for some of these issue reasons, we can also have external factors playing the role, such as radiation, chemotherapy, surgeries, etc. So if we are talking about premature ovarian failure, we have non-functioning ovary. There is an ovary with most tissue is fibrotic, and we cannot see antral follicles there. There is a lot of definitions how we can call and the reasons why there is a premature ovarian insufficiency and how to manage these women with this status. If we are talking about etiology, still there is some percentage of those being idiopathic, so we cannot find the reason, but for many there is a genetic, and if we are talking about genetic, this is X-linked pathology, like monosomy and Turner syndrome, trisomies, deletions, translocations, fragile X mutation, or autoimmune ovarian damage, or some infections, and also iatrogenic, as I said, like oophorectomy, ovarian cystectomies, chemotherapy, radiation, pelvic vessels embolizations, or environmental toxins. The symptoms of premature ovarian failure would be irregular menstrual periods, amenorrhea, hot flashes, night sweats, insomnia, vaginal dryness, decreased libido, painful intercourses, and infertility as the final point, if we are talking about fertility issues. If we would like to test those patients, we would need to do the karyotyping for diagnosis of Turner syndrome, test for Y chromosomal material, fragile X testing, autosomal genetic testing, and antibodies such as thyroid antibodies. And depending on what conditions will be founded, we need to send that patient also to the consultation of the endocrinologist, cardiologist, geneticist, or other specialist, also considering the status that if there is a fertility treatment planned, we need to understand the needs. What should be the next? Like if we need to decrease the antibody activities because we need to have a successful implantation, we need to work on this together with endocrinologists. But if we would not decrease the antibody activity, we will not be successful in terms of the implantation. So it's not only one cause of the issue, because if we are talking about menopause, this is very important to understand that menopause does not mean that we cannot be pregnant. Menopause just means that we cannot produce our own follicles and our own oocytes. But still, there are options of how, by help with the IVF specialist, how to get pregnant. And we will talk about those options. So even if you are in your premature ovarian failure, or you are in early menopause, or you are in your natural age menopause, but you still have plans to be pregnant, it's still possible until there is not a level, the upper level of the legal limit. This is another issue, and those limits, they are in different countries. IVF regulates differently. We all know this. For example, Ukraine, the country where I'm practicing, there is no upper limit by law. We only control this on the ethical committee in our facility, for example, and also considering the somatic status and the risk for the patients. But of course, we will work if there is a possibility to perform successful IVF treatment. So what would be the implications for relatives of women with premature ovarian failure? And this is if you know that if in your family there is somebody who is a carrier of X-linked disorders, you need to be tested as well. So all relatives of women with the fragile X premutation should be offered genetic counseling and testing. And also like control the status of everyone in the family. Also, it is important to understand that we should not remember only about issues related with the fertility, but also if you are in the period of your early menopause or syndrome, being premenopausal syndrome, etc., you need to take care about your bones, your cardiovascular risks, and of course the fertility, but this is what we are talking about. There is a very efficient and what needs to be used. This is menopausal hormone therapy for the management of premature ovarian insufficiency and also patients in their premenopausal periods. This could be either estrogen or micronized progesterone or combination of estrogen and progesterone, including or not including testosterone, etc. But this is very individual, and only after checking individual patient, we can decide what is recommended for this specific patient. Because again, if we are talking about possible implantation, we need to keep cycling, and keep cycling we can only with the hormones, with the external medications. And if we are talking about possibilities of getting pregnant, I love these graphs, which says that independently that the success rates of fertility treatment decrease with age for women after they're 35 years old. And we see the graph getting absolutely down after 44, closer to 46. We have another graphs of stable success rates of over 50% for the same group, for all groups of the patients. This is with using oocyte donation treatment. And this is true in good facilities like ours as well. You can even get higher success rate with oocyte donation treatment. So patients who are dealing with the poor oocyte quality and experience several IVF failed attempts due to impaired embryo development, or who are not producing their own oocytes and they have to be treated with the conventional egg donation programs to be able to have a child. But it is very important that the facility where you are going to perform your IVF treatment or oocyte donation treatment will have advanced procedures to check the quality of the oocytes, also for oocytes donors, because this is very important. And we need to remember that every woman, even if this is a young, healthy woman, she can be a carrier of different disorders and different mutations, and some of her oocytes will be aneuploid. Also, due to the status of the COVID, I like to share this slide that there is a practice which changed, that patients should not travel for all kind of IVF treatment, even with oocyte donation, from their home country if oocyte donation is legal there. We may cooperate with your clinical facility, and it is possible to bring oocytes into your facility, into your home country, and you can find out how this can be done. But if we are talking about oocyte quality, it is very important to say, if you are still producing yours oocyte, even if this amount is really, really small, we need to find out what would be the quality by analyzing the egg cytoplasm, perivitalin space, polar body, and more morphology of your oocyte. And it is important to say about mitochondria, which is a battery of a cell. And age-related changes in oocyte mitochondria means that if we have decreased mitochondrial DNA levels, it causes morphological changes and increase mitochondrial DNA mutations. This all plays the role that finally we have lower IVF success rates, we have lower fertilization, and we have higher aneuploidy rates. It's all because of age and because of mitochondrial dysfunction. Even if the nuclei and the DNA material, the nuclear DNA, is fine. That's why oocyte donation also has alternatives right now. Mitochondrial degeneration will decrease chances for getting pregnant, and the age of egg and mitochondria will get run down, and mutations in the DNA with the lack of energy does not allow embryos to sustain fertilization. In this case, we can solve the mitochondrial degeneration, and we will have the chance to repel nuclear functions inside of the oocyte. And each couple has social and genetic rights to carry up their own genes during the pregnancy. Egg donation is always easy alternative, and it's very effective to achieve pregnancy, but still there are psychological and ethical thoughts which are not considered by all patients. And individual patient has the rights to select if there is availability to select from the methods. And these methods are spindle transfer or pronuclear transfer, meaning that we are using nuclei of your oocyte if you are still producing it, and we are just changing the mitochondria from the donor oocyte. For this case, DNA, which is in mitochondrial DNA, these are 2% of the DNA, and 98% of the DNA, it comes from the nuclei. And this is also a nice graph, which is saying that percent of abnormal embryos for oocyte donors and for women patients in their age less than 35 is 30% and 40%, Meaning, if we are working with oocyte donors, we need to understand that in the cohort of healthy, well-detected, morphologically well-selected oocytes, we will find about 30% of the oocytes which will lead us into the abnormal embryos, because this is nature. We cannot avoid this if we are not testing this. That's why oocyte received, they need to be checked for the genetic status. And what we are offering right now, this is oocyte NGS testing and PGTA testing of the embryos. And again, in Ukraine, this can be done just by request of the patient or according to the medical indications, and advanced maternal age would be or could be a medical indication as well. And the unique feature of the female gamete is that the polar body can provide beneficial information about the genetic background of the oocyte without destroying this. So we can get just the polar body biopsy from the oocyte, and we do know the chromosomal and genetic abnormalities which can be inherited by the offspring. And this is procedure which has no risks. We need to vitrify them one oocyte per straw, because after sending the polar body for the laboratory for testing, we need to identify each and every oocyte. So advantages of polar body NGS testing from patient perspective are very clear, as egg donation program mostly bring financial responsibilities for patients, and each oocyte for patient looks as a potential embryo from the patient perspective. Euploid potential oocyte will have big chances to achieve good quality euploid blastocyst. We also need to consider the male factor, of course, and we cannot avoid this, but we have advanced technologies which we call sperm chip, and still we can increase much more the potential of euploid embryos in this using these technologies in the way of the oocyte donation treatment. And most of the egg donation programs in different clinics does not require NGS or PGS testing for embryos before the transfer, but euploid embryos as well as euploid oocyte will give us the highest probability for the implantation. And as we are willing to bring patient to the successful pregnancy from the first and initial attempt in our clinic, we are checking by all this, and we are using all these advanced techniques. As well as we remember about factors of implantation. And these factors are not only to create, of course, very important is to have euploid embryo. But we already understood that by doing euploid check for oocytes and euploid check for embryos, we can access the healthy embryo. But also implantation potential of endometrium. That's why we need to have hormonal replacement therapy for those patients who are in their menopausal period or premenopausal period or premature ovarian failure, etc. Like all this group of the patients, their uterus should be a point of control of the IVF specialist. We need to check that we don't have a thin endometrium. If we have thin endometrium, we need to treat thin endometrium, and we can treat it either with growth factor or PRP treatment. We need to do hysteroscopy prior to the procedure if we have any questions, if we are not sure about the conditions of the endometrium and the cavity. We are checking individual window of implantation for many patients with previous repetitive negative outcomes, because you can see on the picture here, pinopodias. This is a specific structure in the endometrium which grows in the specific timing. And this is timing when the embryo should be implanted. So we call this window of implantation. And different other factors like thyroid function and immune system response. So by controlling all these factors and checking them, we can make sure that we evaluated everything and we did our best in order to make sure that this patient is well prepared and well treated before the embryo transfer. And having these just two options, healthy euploid embryo and well prepared responding endometrium, we will be successful. We are successful. Another option which quite often is used by our patients, this is so-called combined oocyte donation. So for all patients who still may produce their own oocytes, we are offering cycle of their stimulation. Sometimes this is after PRP preparation, PRP treatment, which we call procedure ovarian rejuvenation. And then patient responds, one or two oocytes, we cultivate them in a different dish. But additionally, we have another dish with the prepared donor oocytes previously selected by the patient and performed ICSI, and cultivate them in two different dishes. By using this method, we are not losing embryo transfer potential, because for many patients who are trying their last chance using their own oocytes, quite often we don't have blastocyst for transfer due to the fact of, you remember, mitochondrial activity, euploidity activity, etc. But at least we have this backup from the donor material and we can successfully transfer finally. But we have this emotional stability that we tried our best. We did what we could. We received oocytes, we fertilized, we cultivated, we selected, we checked morphology, but unfortunately, so this is the way we should use for being successful. So to conclude, menopause is a physiological conditions, of course, better to predict and better to start your treatment earlier, because then you will be able to produce your own oocytes and we will have more options for the successful treatment. Genetic factors are related to the occurrence of the menopause. In case the fertility treatment is planned, options for successful treatments are available, and advanced techniques are developing to improve success rates and treatment options. Thank you so much for listening. As always, it was a pleasure to spend time with you, and I will be happy to answer your questions now.
Thank you so much, Uliana. As always, it's great to have you, and it's been again a brilliant presentation with lots and lots of details, and you have explained everything. So you took us step by step how it can be managed as well. So thank you so much. It's always great to have you back. That's for sure. And of course, yes, now it is time for your questions. At least for now, there's one question, but of course, you know what to do. Okay, just go ahead, type anything that's on your mind. You can ask, and I'm sure Dr. Uliana will be happy to answer them for you. And let's have a look. Okay, Kate has added first question here. So how common is premature menopause, early menopause? Has it become more common in recent years?
Thank you, Kate. It's a great question. Our average age of our patients being treated in our facility is 42 years old. And I should say that every year, the average age of our patients is increasing. By increasing the age of the patient, of course, the probability of having patients with the symptoms of premature menopause or early menopause is also increasing. And this is all over the globe. We even, like, there is a publication that every 10 years, every decade, the age of the first deliveries of the baby is increasing by 2 years, all over the globe as average, meaning that if we would calculate for the future, so in 2100, the first delivery would be in 51 years old, meaning we as IVF specialists, we need to be ready to offer the options for those patients. Of course, the best options are to freeze the eggs, like to freeze your fertility, your natural fertility, or freeze ovarian tissue. And still there was a discussion, a huge discussion before the COVID, like probably 2 years ago, that if we will take a piece of the ovary, what we do for our patients with the oncology, and we will freeze the ovarian tissue, and then we will transplant the piece of the ovarian tissue back into the ovary, this tissue will start produce hormones and we will delay menopause. So, and this option was offered to the patients to delay menopause. But of course, by ethical committees, it was not accepted. Like just to make surgery, to delay something what is physiological with no medical indications. But still, this is something what we are already talking about. So it's very common, and it's more and more in our patient populations and all over the globe.
All right. Thank you so much for definitely very interesting question. And of course, as always, great answer to that, and definitely interesting. As you can see, someone even wrote what. So this is something surprising for some of the patients for sure. It's definitely interesting to know. Yeah. Thank you so much. And now we will have a bit of a longer question. Let's have a look. Okay. While I'm single and already in early menopause, what can I do now to look after myself? I am 42 and still desire pregnancy in my life. If I was married now, I will rush to try for a baby, but no man. Yet I feel like I'm leaving it to a chance now. What resources do you have to help me?
Great question. Thank you for, and this is a time to take care about yourself, definitely. What I can say in terms of, there are the guidelines for fertility preservation that we should recommend fertility preservation for patients in their age before 38 years old. Just because of the statistical data that before 38, potential aneuploidity rate would be lower than if you are older. And if we are freezing oocyte in the older age, we can just, like patient can spend money, we can get low amount of oocytes, lower quality of the oocytes, and we will end with no result. So this is again ethical, financial, etc. question. However, from our practical experience, we also know, and we were talking about these PCOS patients. So I definitely know, and there is a correlation, that if a patient was a PCOS patient, she can still respond with more than 5 oocytes or even closer to 10 in her over 40 years old. It all depends on the individual response of the patient. Of course, many of them would be uneuploid, and probably I would recommend to test them. Even if there is no male partner, there is a potential to freeze the oocyte. There is a potential to use donor sperm, but it's very individual decision. But what I would definitely recommend that if you are already, you have signs of your early menopause, you need to check your IMH, you need to visit your fertility specialist, you need to check number of antral follicles, you need to consider fertility preservation. Like any doctor can say because still there is a possibility for you to getting treatment. You just need to understand the risks associated with this. Or doing a treatment with sperm donation and then moving ahead from there. So everything is possible, but also you need to visit your endocrinologist and cardiologist to check your status regarding symptoms of early menopause and your somatic status. I had period in 12 months now. So, okay, so it's not premenopause, it's probably menopause already, but again, it would be great to check IMH, to do the ultrasound evaluation, but still you will be able to carry the pregnancy using oocyte donation if you would decide to do this. Some women, they consider even embryo donation, but you still can be pregnant, you can carry the pregnancy, and many patients, they share their emotional status that they feel that this is their baby. And there are a lot of publications regarding RNA we exchange even if this is oocyte donation. So still there is some genetic your part of you, and during the baby growing period you will be with the baby. So still, this is a good time to think about and to plan about, and don't delay this.
Of course, thank you so much for sharing, yes, and also, of course, for your answer. And there is a comment, okay? So let me just show you. So I never heard about premature ovarian insufficiency, early menopause until it happened to me. First time since 39. It's the same, yeah. So it was from the same patient.
Unfortunately, yes. So sometimes it's happening, but still you are young, and you can get pregnancy with other alternative methods, and you should not delay planning this independently what you would select. Some women, yes, many, like 1%, it's already, I even think it's more than one, and maybe this is ecological factors playing the role, etc. We don't know, but we started to see more patients with the premature ovarian failure, unfortunately.
All right, thank you for the clarification, of course, as well to this one. And let's have a look, okay? Next question from Sylvia. What has the best success rate, IVF with fresh or frozen egg donation?
Sylvia, frankly speaking, for probably, like, I'm lecturing quite a lot, and I already included in my slides that fresh oocyte donation, it was a gold standard 5 years ago, and now vitrified oocyte donation is a gold standard. However, there is some limits, and we need to consider few factors. The most important factor is the facility who did the freezing of the eggs. Sorry. And also the facility who is going to do the sewing. These two technologies, they are very simple, they are very commonly used. However, there are different laboratory conditions and different embryologists. And in our oocyte banking data, we have real data coming from different clinics. Even we recommend to follow the protocol, and even we know the team and the embryologist who did the vitrification by doing sewing by different embryologists in a different conditions of the air quality, humidity, temperature, protocol used, volume of the media used, they are getting different results. So if you are not sure about the facility and the conditions for the oocyte vitrification and sewing, it's better to use fresh, probably. But fresh also has some advantages and disadvantages. And advantages that it's more commonly used in some locations, in some laboratories. But disadvantages are that donor can not respond with the expected number and quality of her oocytes, even if her previous cycle was fine. Like something happened, she missed the medication, she mixed up something, she forgot to do the injection, you was synchronized, but you needed more time to prepare your endometrium, and donor follicles were already big enough to do the oocyte pickup. But because you are synchronized, doctor decided to postpone the pickup for sizes of follicles of 24, 23 millimeters, and the oocyte quality, of course, will be not optimal in this situation. So this asynchronization and the risks that the donor will do something wrong are also, I would say, they're also huge. So I would recommend just to consider the facilities which have the best results for oocyte vitrification and sewing. Mainly these are facilities who do a lot of those cases, and their results are wonderful. The working result is over 95% of the oocyte being survived, and there is no difference in fertilization, blastulation rates, and clinical pregnancy rates.
All right, again, fantastic. Thank you so much for answering yet another question. And let's have a look at the next question from Sylvia. Do you use alternatives for oocyte donation at your clinic?
Yes, we do everything what I mentioned. We do pronuclear transfer and the spindle transfer and combined oocyte donation program. Like everything what was mentioned, we do successfully in our center.
And thank you for the clarification to this question as well. And let's have a look. Next question is definitely interesting as well. Do you use medical approaches for the treatment of premature ovarian insufficiency? Example, cycloprodinova?
Yes, we do. Like for all patients who are coming to visit us, but mainly those who are coming to our facility, they are looking for the pregnancy. And if we are talking about pregnancy, even with their diagnosis of premature ovarian insufficiency, then we are considering if we still can consider stimulation. And if we are considering stimulation, we are using recombinant FSH to grow the follicles if they are existing, or if we are moving to the oocyte donation, we are moving to the treatment of by oocyte donation. And cycloprodinova is usually used for preparation of the endometrium of those patients. But if this patient is not, for example, for some reason, she is not ready to be pregnant right now, of course, we recommend the hormonal replacement therapies, because it is very important for also health of the bones, of the, all these conditions, even sexual feeling, intercourse, vaginal dryness, etc., etc. So these women, they need to have replacement therapy, hormonal replacement therapy. It can be different, but it needs to be selected individually, case by case.
That's understandable. Again, thank you so much for yet another interesting question. And it looks like that might be our final question. But of course, if you have any left, go ahead, type those in. This is like the final call for the questions. And again, another interesting question. Is it true that PRP treatment and gonadotrophins might restore ovarian function in women during early menopause? Is there any evidence?
Thanks, Kate. We do a lot of research, and we were sharing our data regarding the PRP treatment. We divided the group of our patients into the groups of potentially being good responders for PRP, and those for whom we should try, but we should not expect wow effect, let's say. And from what we understood how PRP works, that once we are injecting PRP into the ovaries, we are helping those follicles which are existing in the cortex, because they are still there. So if we are cycling, even if we do not cycling regularly, we still have about 100 up to 500 follicles in our ovaries, but they are in a different stages of their development. And follicles needs to be on a stage being sensitive for gonadotropins. So by injecting PRPs, we are helping follicles which are in their preliminary stage being unsensitive to gonadotropins to grow faster, a little bit faster, to be sensitive. And after injection of the PRP, we see mainly after 2 months, or in a period after the injection up to 2 months, that we started to see small antral follicles in the ovaries by doing ultrasound evaluation. For all patients, we saw decreased FSH, decreased FSH, and a little bit increased IMH because it's quite sensitive. And for some it was increasing, for some no, but still we saw antral follicles. And as soon as we saw antral follicles, we started our stimulations. So it works well, but it works best for this category of women who still have some IMH. Like for us, this cutoff was 0.3. So if patient had 0.3 and more, if she was not after, like our oldest patient was 47, but she was just like, she was trying everything to get pregnant. Unfortunately, PRP was not working for her as well, and we moved just to the regular oocyte donation. But for many patients, and mainly for their age less than 42 and IMH over 0.3, it works really well. And evidence, there is no, like, it's considered to be a clinical trial or experimental treatment, and we signed the consent with each of our patients for experimental treatment, but there is no risk. We need to understand that PRP treatment is used commonly in different areas of medicine, in traumatology, in cosmetology, in trichology, everywhere, and it works. So as well, it works for gynecology and fertility.
All right. Again, thank you so much. Great question indeed. And of course, as always, thorough answer. Let's have a look. One more question is right here. If you can advise, I'm seeing my GP this week. She's referred me to gynecologist on the 28th, and I have vaginal scan on the 8th. I have never been sent to an endocrinologist or cardiologist. I had done blood tests. Should I request to be referred to these two specialists?
Yes, for your somatic status, you should request to be referred, and there is a special test which needs to be done in order for your bones and for your cardiovascular system. But in terms of your gynecologist, you can also discuss an issue, and if you will have a need, like, I don't know which country you are located, but if you don't have an opportunity to be treated with those, like any kind of advanced techniques like we are offering, or even oocyte donation, because it's very limited in some countries, or there is no options for oocyte donation, you can always travel. And right now, the travel restrictions are like, there are almost any. You just need to be either vaccinated or do the PCR testing, and we will coordinate and plan all your visit and the activities in our country in case this would be needed. But of course, a lot you need to do at your home country if we are talking about all other options, not directly fertility.
Wonderful. Again, thank you so much. And there's a follow-up. Once again, let's have a look. If I still want to wait a bit for husband before baby, should I do hormone replacement therapy? Which one? Any side effects? Any risk if I don't use it at all?
Yes, hormonal replacement therapy should be advised, but after performing the hormonal profile and the ultrasound evaluation, so probably your gynecologist will advise you, or you need to ask her or him to advise you hormonal replacement therapy. Side effects, they can be connected to the thrombotic status and your vessels. But again, this will be checked before the hormonal replacement therapy will be advised. And these risks, they are very minor risks. But to be more specific, you can contact us if you need to have a second opinion, but better to go to your gynecologist, ask all those questions, and then if you need to check anything else, or you need to double check, or as I said, second opinion, you can write. But we would need to be more specific in terms of what is your today estradiol level, what is your progesterone level, what is your FSH, what is your ultrasound evaluation, etc., before we will be happy to advise anything.
Once again, thank you so much indeed. And of course, there's one more question that we have, okay? What do you think about DHEA? Do you think it helps with oocyte quality for women over 40?
Thanks, Sylvia. It hasn't been like there was probably maybe 3 or 5 years or maybe 6 years ago, there was a boom regarding testosterone and all other supplements which consist testosterone. And many clinics, they are offering this supplement to their patients, including it in the protocol or advising to take it before the treatment. We also but still, according to the Cochrane database and to the scientific publications, and this still was more commercial than it was confirmed by the real science and evidence. We understand that for some women, some testosterone would work well, but it was not as a category A that it should be included in all IVF treatment regimes. Personally, me, like some of my patients, they accept different supplements. Like we include also vitamin E, coenzyme Q10, some others. We have a list. I created a list of what we would advise. But again, we need to know more about that patient. We need to receive some of her results. We are asking for some specific, and we need to have medical history of that patient. So based on this, we do recommend some supplements or we don't. But we need to understand that there is no evidence-based confirmation for this specific medication as well. But my personal opinion that there is no harm if you are not getting more than it is advisable, like maximum is 3 times per day as maximum 25 milligrams, so total 75 milligrams.
Excellent. Thank you so much for that question. Definitely it's a question that we do receive quite a lot, actually. So thank you so much for answering this. And it looks like that was our final question. But of course, remember that if you would like to get some more answers, you can simply get in touch with Dr. Uliana, her team at IVMED, and I'm sure they will be happy to help out. So don't hesitate, okay? And we will be finishing for tonight. So again, thank you so much, everyone, for joining us, and of course for your incredible questions, of course, and for your thorough answers. And as you can see, Dr. Uliana, there are some thank yous for answering the questions. Great and interesting presentation. Thank you so much for answering. It was a pleasure to listen to you. What can I add, really? Maybe you would like to add something, Dr. Uliana.
Yes, of course. I would like to thank you all. It's always my pleasure to join. I already, if I am not online with you during a month, I am missing this so much. So thank you for joining. Thank you for being active. Thank you for asking questions. It is my pleasure to communicate with the patients who understands what is going on, because we need to cooperate. I always saying to all my patients that we need to work together. This is not just my responsibility. This is our mutual responsibility, and I will do my part, but patient would need to do her part, also partner needs to do his part, etc., etc. So this is a big team of moving together toward to the goal. And if it is happening like this, it is always successful. So I wish you all success on your journey for parenthood. Please don't delay, because this is so important resource we all have. And I believe everything will be great. So take care during this complicated period of COVID, but don't let this period to delay as well. So already everything is possible. You just need to find the best route.
Amazing. Thank you so much. What can I add really about when it comes to that? You just summarized it perfectly. It's always a team's work. So thank you so much. It's always great to have you. And well, I have very good news for you actually, because next week, Dr. Uliana will be back, okay, with more topics, of course. And so I'm very excited because the next topic is, will the baby look like me? So this is always a question that we do receive very, very often. So if you haven't registered yet, go ahead, do it. I'm sure it's going to be interesting as well. Thank you so much. And of course, you will be able to find the recording of this webinar on our website, which is myivfanswers.com, and it will be available on our YouTube as well. And well, take care, everyone. Have a lovely evening. Dr. Uliana, again, it's a pleasure. I'm very happy that we will see each other on next Thursday, right?
Thank you so much. Take care. Bye.
Thank you. Bye.